Okay, how about now?
Good job.
Yeah, we see.
Yep. Big blue screen, my name, logo,
Yes.
and all that. Okay, so again, for those of you who are not familiar with me, my name is Charles Gaba. I am the founder of ACA Signups.net. It's a website, blog, devoted to all things ACA related. Started it way back in fall of 2013 at the launch of the first open enrollment period back on October 1st, 2013. You may recall healthcare.gov, the federal ACA exchange website launched and immediately crashed. And it was a big, ugly technical mess. And anyway, long story short, it was pretty messy. It took a while to clean up, but they got it. That's when I started doing this. I'm actually a website developer by trade, or at least I was at the time. This was supposed to be a 6-month hobby, and now it's 7 years later, and here we are. So I'm still doing this. So, okay, so ACA 101, the law and the lawsuit. So the thing about the ACA that I always try to explain to people is that Medicaid and Medicare are fairly easy to explain to people. You know, they're easy to, I mean, they're complicated, but they're easy to explain. You know, Medicare is basically a form of single payer or semi-single payer, mostly for senior citizens, but also for some folks below 65. And then Medicaid is basically single payer or near single payer for lower income people. And again, there are exceptions. I'm vastly oversimplifying it, but that's what it amounts to. The ACA is much more complicated. I consider it a Swiss Army knife. It's a whole bunch of stuff, and most people are familiar with 2 or 3 of the major provisions. You know, you got the 2 big knives, you got the big knife and the scissors that you know what they are, and then there's all these other weird little tools, and you know, you got the hole punch and the awl and that sort of thing that nobody ever uses, or they don't know what they're for. And that's what I always think of as the ACA. People generally know, by the way, can you see the cursor if I move the cursor around? Like the pointer? Yeah, okay, good. So, you know, people generally know about the ACA exchanges. Most people know that there's some federal subsidies available for people. They know about Medicaid expansion. And of course, the big story of the last 4 years, you know, the official name, the full name of the law is the Patient Protection and Affordable Care Act. And everybody shorthands it as just the Affordable Care Act or just the ACA. And they always drop off the patient protection part, but that's the part that's really been, you know, in the news a lot the last few years, is the protections for people with pre-existing conditions and so forth. By the way, I don't know, is there a way to know when somebody's waiting in the waiting room while I'm sharing? Does anybody know Zoom that well? I don't know if there's somebody waiting or not.
Yeah, if you
I may pull out of, what's that?
If you look above the chat, it usually is right there, I believe, or participants. Look at the participants. Oh, that's what it is. Click on participants.
Oh, right, except that I'm screen sharing, so it changes a little bit. Okay, well.
But it's
right.
in participants.
Okay, yeah, I think I see it. Okay. Anyway, so yeah, you've got those that people know about, but then there's all this other stuff that a lot of people aren't familiar with. For example, the Medicare Part D donut hole. There was a flaw in the Medicare Part D for prescription drugs and how that was paid for and so forth. And the ACA, one of the provisions of it is that it basically closed the gap. There's a chunk where people on Medicare Part D had to pay a huge chunk of their prescription drug costs, and that was fixed as part of the ACA. And so if the ACA were to be struck down, then that donut hole would open right up again. And there's a whole bunch of other stuff as well. Okay, so this is where I'm going to get started. What you're looking at here is something that a friend of mine, actually the House Minority Leader of the State House here in Michigan, calls the psychedelic donut. And what it actually is this is the entire US population, all 330 million of us, in terms of our current healthcare coverage. Now this is a couple of years outdated. This is from around 2017. So since then, the you know, the sections have shifted as people have lost coverage or have shifted from one type of coverage to another, but it's still mostly accurate today. This is what it looks like. The big green section that takes up about 40% of the right side, this is people with employer-based coverage. The large group market is companies with over 100 full-time employees. The small group market is between 1 and 100 employees. You also got public employees at the federal, state, and local levels. You've got the military, people with, in the military with TRICARE or people covered by the VA, Veterans Administration. But that all still counts as employer-based coverage, right? And that's almost half of the country. And that fact, the fact that almost half of the population has their healthcare coverage through their employer, has been a huge part of the debate and the discussion and the argument over the past, well, for a long time, but especially over the Democratic primaries, right? About would Medicare for All force people to give up their employer-based coverage or not, versus a public option, that sort of thing. So that's why, because it's almost half the country. Down at the bottom here in the orange section here, this is Medicare, and there are different of Medicare. There's traditional Medicare, there's Medicare Advantage, and there's people with traditional Medicare, but who also have Medigap, which is total coverage, and so forth. But so that's this chunk down here. Over to the right, or on the left side in burgundy, this is Medicaid. And these days it's around 4 million people. Americans are covered through Medicaid. The straight burgundy is pre-ACA Medicaid and the CHIP program, the Children's Health Insurance Program, from before the ACA. This area here is where it overlaps. Those are dual eligibles. Those are people who are enrolled in both Medicare and Medicaid. So if you're over 65 and you're low income, then you might be eligible for both. There's a few other folks in that category as well. Moving up to where it sort of starts fading into blue. These are the two main parts of the ACA that people are familiar with. Oh, okay, yes, when somebody new enters, it does pop up and say someone else is waiting. So there you go, great. So basically these two slices here where it's sort of bluish, the first one is Medicaid expansion. That's the portion of the population that was not eligible for Medicaid before the ACA, but now they are across 38 states so far. Then this other section, which is sort of blue and yellow, this would be the ACA exchange market, which gets so much attention. Those are people who enroll through healthcare.gov or Covered California, or some states have their own state-based ACA exchange or a website. That's where all those folks are enrolled, and that's there's around 10 million people, give or take, enrolled through the exchange plans. Then you have in pure yellow, this is the off-exchange individual market. Basically, the yellow, these are people who are not covered through their employer. They're not covered through Medicare or Medicaid. They have private health insurance, but they had to buy it on their own because they don't have an employer to provide it for them. Or like in my case, I'm self-employed. So, there is no employer-based coverage and I'm not eligible for Medicaid or Medicare. So I go on the open market. That's called the individual market or the non-group market. And that's where most of the controversy and confusion and fuss about the ACA has been about this whole yellow section, even though it's such a small portion. The reality is the ACA affects every aspect of the US healthcare system in different ways, but these areas are where it has the most obvious impact, and that's in the most news. The off-exchange market means something that a lot of people don't know is that if you are self-employed or your employer doesn't provide coverage and you want to buy insurance, you don't have to go through the ACA exchange, except in DC. They require you to. But everywhere else in the US, you can still go directly to Blue Cross or Medica or Humana or whatever it is and enroll in a policy. The difference is that if you that in order to be eligible for subsidies for financial assistance, you have to do so through the exchange. That's the major difference. This slice has actually, the pure yellow slice has actually gotten much smaller over the last few years since I put this together. It has shrunk. This is the unsubsidized individual market. Then up here you've got these little gray slivers. This is sort of miscellaneous. You've got the Indian Health Service, which is actually, it's actually public health coverage. I probably should have put it down here, but you've got a few million in there. University students, who are in university plans, which are they're sort of individual, but they're also, it's not your employer, but it's still a large institution, so they have sort of a special category. Then you also have sharing ministry plans, which a few million people are enrolled in, and there's various other types of plans. And then you also have the so-called short-term plans or association plans. Administration has been pushing hard the last few years, and I'll get to that a little later. And then, of course, you have, sadly, the uninsured, those who have no type of coverage whatsoever. At the time, in 2017, it was around 27, 28 million people. These days, it's up well over 30 million. It had already gone up, I believe it had broke 30 million even before the pandemic. It dropped. Before the ACA in 2013, it was almost 50 million. Around 48 to 50 million people were uninsured in the US. The ACA famously locked that down by about 20 million or so, but it has slowly crept back up again. And then, of course, the pandemic hit. And that's the other reason why these colored sections have shifted, of course, because there's more unemployed. Millions of people have lost their employment, and so there's millions more who are now on Medicaid or on the individual market through a subsidized plan. And then of the uninsured, there are various reasons that there's different categories of what they're eligible for and so forth. There are several million people who are eligible for Medicaid or for subsidized ACA plans, but they just don't know it, or their state may make it very difficult. They may put a lot of hoops and paperwork and red tape and stuff. Also, for some people, there's a stigma. Some people don't want to admit that they have to be on Medicaid, that sort of thing. So that's this category here. So yeah, that's the psychedelic donut. Oh yeah, as I said, this is outdated. The green section is much smaller. The yellow section is much smaller. The burgundy section is larger, and sadly, the white section up here is larger as well. Okay, I'm going to briefly speak about Medicaid expansion. Most of this is going to be about the individual market because that's my bread and butter. That's my main thing. But basically, before the ACA, adults who didn't have children under 18, right? If you have adult children or you don't have any children, if you were not disabled, if you were a so-called able-bodied adult, I'm not thrilled with that definition, but that's what it's called. Usually we're not eligible to go on Medicaid in most states, regardless of how low their income was, right? If you were dirt poor, but you didn't have any kids, too bad. The ACA expanded Medicaid eligibility to basically any American whose household income is up to 138% of the federal poverty line. Officially, it's 133%, but there's some tax thing, so it's actually like 138%. Which is roughly 21, that's roughly $17,600 per year if you're single, or $36,000 for a family of four, except that if you have children, then your eligibility is going to be different anyway. So anyway, sorry. It was supposed to be, under the ACA, it was supposed to be across the entire country, all 50 states. However, there was a Supreme Court case in 2012, and Supreme Court ruled that Medicaid expansion had to be voluntary on the part of the individual states. You couldn't force every state to do it. They had to volunteer to do it. And originally, about half the states did, half the states didn't. Over the years since then, a bunch of states, mostly red states, have come on board. And so as of now, there's 38 states plus the District of Columbia, which have expanded Medicaid. There are 12 which have not yet. Missouri and Oklahoma both just passed ballot initiatives to expand Medicaid, but that won't actually kick in. I think next year is when that goes into effect. So there's still, that's 38. And then there are 12 states that haven't, which sadly include some of the larger states, Texas, Florida, and Georgia, and North Carolina. So just those four right there, that's, a lot of people who are caught in without being eligible. Just before ACA expansion launched in 2013, or I'm sorry, in 2014, there were around 55 million Americans in either Medicaid or the CHIP program. That's the Children's Health Insurance Program. It's similar to Medicaid, but it's only for children, and it's I think the funding is different. I think that's why it's not rolled into it, but they usually sort of push the two together. As of today, that's up to around 75 million who are enrolled in Medicaid or CHIP, including over 4 million just since February of this year because of the pandemic and the economic drop, and of course the millions of people losing their jobs, their income. So yeah, over 4 million people just in the last, 8 months, 9 months now. So obviously it's kind of an important thing. Medicaid eligibility is primarily based on your household income, but the income threshold varies. I always thought that it was just, there was like one threshold, and if you were over that, if you were under that, you qualified, if you're over that, you don't. It turns out there's a bunch of different categories. So like, it varies in some states depending on whether it's a newborn child under 1 year old, if they're 1 to 5, 6 to 18, if it's a pregnant, if a pregnant woman is a different category, if you're an adult who has children under 18, and then of course adults, so-called able-bodied adults without children under 18. So depending on, in some states, that income threshold it jumps up and down, which is kind of crazy because that means that, in the course of like 2 or 3 years, even if your income stays exactly the same, your eligibility or your child's eligibility could bounce around back and forth, which doesn't make much sense to me, but that's what it is. According to a friend of mine, by the way, Andrew, he's a great guy. He may even be here, I don't know. He runs a blog called Ex Post Factoid. I highly recommend it. Medicaid enrollment through ACA expansion specifically is up almost 20% just since February because of the pandemic. So that it has been Medicaid expansion has been a godsend for millions of people in this pandemic. Total Medicaid enrollment through expansion specifically is around 15 million, I believe. So of that 75 million, around 15 of that is specifically due to Medicaid expansion in those 38 states. This is just, like I said before, this is outdated by a few years, but basically this just breaks out the different categories I mentioned. And as you can see from the percentages, this is the percent of the federal poverty line where each state sets the eligibility. So, like in Arizona, a newborn child under 1 year old, well, actually up to 5 years old, I'm sorry, 147%. If they're under 1, it drops to 141% from 1 to 5, then to 133% until they're 18. And so on. But when the woman's pregnant before the child is born, it's 156%. But then once they're born, the child is, you can see how confusing it is. I'm not sure why there's so much disparity. I assume it has to do with state budgets and trying to save money and stuff. And then this category over here, this one here, adults, you have parents, and then other adults. This is basically Medicaid expansion, is what it amounts to. It says 133. Like I said, it's actually 138. But there you go. DC actually has a higher threshold to begin with. Adults without children, I believe this was from before the ACA, up to 210% of the poverty line were already eligible for Medicaid anyway. So it really I don't think it really affected DC specifically. And then if you look, you'll notice like some of the states where they have not expanded, like Alabama, for example. In Alabama, not only if you don't have kids, you are out of luck. You do not qualify for Medicaid. If you earn $1 a year, doesn't matter. You can't get on Medicaid. If you're a parent, a low-income parent, you can only be up to 13% of the federal poverty line. The federal poverty line for, let's say you're a single parent, 1 adult, 1 child, I believe this federal poverty line for 2 people is something like like $16,000 a year. So 13% of that, that's your cutoff. Honestly, I'm not even sure why they bother, you know, that to me, that almost seems cruel to, you know, to have it, like you're just messing with people's heads, but whatever. Anyway, this is the status. These are the states which have expanded in blue or dark blue here. The orange states are the ones that have not as of yet. Again, Texas, Florida, Georgia, North Carolina, et cetera, mostly the deep South. And then again, Missouri and Oklahoma, they both just passed ballot initiatives to do so. Last year, 3 states, Idaho, 3 red states, you know, very right-wing states, Idaho, Utah, and Nebraska, all passed similar ballot proposals. So that's been the main way that it's been expanding in the states that weren't doing it, you know, where the legislature or the governor wasn't, is basically the people have just been saying, we want Medicaid. So, however, the states that have not expanded have something called the Medicaid gap. And here's why. The ACA, the original idea was that if you were earned between 0 and 100% of poverty, you were supposed to be on Medicaid. If you earned between 100 and 400% of poverty, you were supposed to be eligible for the subsidy, you know, private plan, but subsidized by the federal government. And then if you were over 400%, then you were supposed to pay full price, right? The problem is that it assumed that all 50 states were going to expand Medicaid. And so when the Supreme Court said it had to be up to them, some states didn't, which means that in those states, if you earn below 100% of the federal poverty line, you ironically do not qualify for Medicaid, but you also do not earn enough to qualify for financial subsidies. I know that sounds ridiculous, and it is, but that's just the way it worked out. The subsidies cut off between 100 and 400%. So if you're 99% of poverty line, you need to earn $1 more. In practice, however, an odd thing happened. I mentioned 138% is the top cutoff. There ended up being somehow in the way that the law was passed, I don't know if it was a drafting error or what, there was an overlap between 100 and 138. So Medicaid goes up to 138%, but the subsidies start at 100%. So if you earn between 100 and 138%, there's an overlap population where you were supposed to be on Medicaid, but you do qualify for subsidies instead. So that's why they have on this chart, this is from the Kaiser Family Foundation, by the way. Great resource, great organization. And so they break out, these are the number of people caught in what's called the Medicaid gap. Basically, this column here is those who earn below 100% and live in the states that haven't expanded Medicaid yet. And then there's another population where they're between 100 and 138. And so they don't qualify for Medicaid, but they do qualify for very heavily subsidized, like 99% subsidized, in some cases, private plans through the exchange. And as I said, it's a little outdated. Missouri and Oklahoma are about to be scratched off this list, thankfully, but that still leaves, you know, several million. That's over 4 million total. Looks like around 2 million people. Those 2 states drop off. Around 2 million Americans are caught in the Medicaid, are going to still be caught in the Medicaid gap, where they're caught between a rock and a hard place. They cannot get decent coverage no matter what because of the states that they live in. Going back here again. Okay, so that's Medicaid expansion. Like I said, that's basically this sort of blue to burgundy slice here. Oh, and something else is shining. Just want to come back here for a minute. And the thing, you know, I mentioned before about the pre-existing condition protections that's gotten so much attention over the last few years. There's a lot of people who think that only applies to the individual market because that's where you hear about it the most. But those protections apply basically to the whole donut, you know, to everybody. There are some provisions that don't tie in with Medicare, I think, because they're handled separately. But basically, if you have an employer-based coverage, those protections apply to you as well. That hasn't gotten nearly as much attention because most employer plans have some of those protections sort of baked in inherently anyway, because, you know, as long as you work for that company, you're eligible for their healthcare plans. So, you know, that's sort of the equivalent of basically you're guaranteed issue as long as you work there, or for up to a year after because of COBRA. So, but yeah, that is important to remember. There are some protections that I don't think were around before the ACA, including, I believe, the removal of a cap on coverage, like annual or lifetime limits. There were a lot of plans, even employer plans, where once you hit a certain threshold of, you know, of claims, you were cut off and you were out of luck after that. So anyway, okay. Okay, so now we get to the fun part. This is my bread and butter. This is what I call the three-legged stool of the ACA, and this mostly relates to the individual market. What you're looking at here is a no-legged stool, right? You've got a stool with no legs that's sitting on the floor. This was basically the situation on the individual before the ACA. There were plans that were either crap, or if they were decent, you had to jump through all sorts of hoops to be able to, basically they could just deny you coverage altogether. But yeah, a lot of them were basically just crap or junk plans. There were other, as I said, there were some good plans that were pretty comprehensive, but the catch is that they didn't have to enroll you. If you came to them and you said, I want to buy, you know, an insurance policy, they would say, well, hold on a minute. And they would require you to provide your entire medical history, every prescription, every operation, every doctor's visit, everything about your entire medical history, any healthcare issue you've ever had. And they would pour over all of it, and you have to get it all together. Like, you have to gather all the documents and send it to them. And then they would say, okay, we'll get back to you. And they'll look it over. And if they decided we're going to be high risk, you know, that you were going to be expensive to treat, then they would do one of three things. They would either say, tough, we'll pass, and they just wouldn't let you buy at all. Or they would say, okay, we'll let you buy a healthcare policy, but we're going to charge you, you know, 4 times as much as this policy normally would cost. Or they would say, okay, we'll sell you this policy, but we're going to include an exemption that doesn't, your policy covers everything that it says except for cancer, or except for diabetes, or, you know, whatever the ailment is, generally the one that is the reason why you were looking for coverage in the first place. That's the reason why, and the thing is that the policies tended to be fairly inexpensive, and that's why, because they could, you know, you never knew what you were going to get, and they could cherry pick their enrollees. That was how they were able to keep premiums low, is they basically could restrict themselves to healthy people. So it's easy to keep your, you know, overhead low when everybody enrolled in your insurance policy is healthy, assuming they stay that way. They also, I mentioned lifetime limits. A lot of them had very stingy. This is from New Era Life Insurance Company from back in, this is before 2014 anyway, an original maximum benefit limit of either $10,000, $20,000, or $40,000. That's not 40 million, that's $40,000, which these days is what? That's like 3 days in a hospital room, maybe. Yeah, there were some policies that, yeah, as a result of healthcare reform, the benefit limit has become unlimited. So they couldn't do that before. The thing is, a lot of the policies would have maximum annual or lifetime limits of, say, $2 million. And that sounds like a lot of money, and it is, except if you're undergoing chemotherapy, or let's say you have a newborn child who is prematurely born, like my son was, and has to stay in the neonatal unit. That could cost like $50,000 a day. There were cases of premature babies who ate up they maxed out their lifetime limit before they ever left the hospital, you know, in a matter of months. And that's lifetime. Like, they basically just became uninsurable for the rest of their lives unless they, you know, were covered through their employer later in life. Again, it's very easy to cherry pick, when you can cherry pick your patient, your enrollees, get someone who's healthy, you know, and you think they're unlikely to become unhealthy, then they would approve them. But if somebody was sick, they could just deny them coverage. That's an easy way to keep your overhead low, to keep your costs low, but it also means that you're leaving millions of people out in the cold. And again, I mentioned the junk plans. A lot of these, again, some of them weren't terrible plans. It's just that it was hard to actually get enrolled in them. And then, but for the most part, they were crap. They had loopholes. They had fine print. There was a lot of fraud. There was a lot of all sorts of garbage. And the ACA was seeking to do a couple of things. First of all, to expand healthcare coverage to as many people as possible. Contrary to popular opinion, it never promised to be universal coverage. It promised to try to expand coverage as much as possible, but it never said we're going to hit 100% coverage for the entire population. It was just, they were trying to chop away at that 50 million uninsured as much as possible. And also was trying to make it more affordable, which kind of goes hand in hand with that. And was also trying to eliminate the worst abuses of the industry, as well as to raise the standard, to give some standard to the coverage that had to be provided. So, first thing it did was something called guaranteed issue. When you hear people talk about coverage of pre-existing conditions, and we heard that over and over and over again, there's actually several things that includes. The first one is guaranteed issue, which means they can no longer refuse to provide coverage. They can that health insurance companies can no longer flat out say, we aren't going to sell this to you. They have to sell you the same policies that they sell to anybody else. The second thing is community rating, which basically means they can't charge you more for that policy than they would someone else based on, whatever they feel like, which is what it used to be. Commonly, they would charge women more just for the same policy, just because they were women. They would charge more based on your job sometimes, based on, of course, your medical history, of course, or what they thought your medical condition was going to be. They can't do that anymore. There's only 3 things. There used to be dozens of things they could base it on. Now it's limited to exactly 3 things. First, your age. They can charge you more for being older, but it's limited to a 3-to-1 ratio. Before the ACA, that used to be a 5 or 6 to 1 gap. So they would charge a 64-year-old up to 6 times more than, say, a 21-year-old. Now that's been cut down to a 3-to-1 ratio at the outside. There are some states where actually they don't allow that, like New York and Vermont. It has to be straight community rating. Everyone gets charged the same amount regardless of age. There's others where Massachusetts, it's 2-to-1, but it can't be any more than 3-to-1. Second thing is where you live. The price for the same policy can vary widely depending on which state you live in, but also within a state, which county you live in. There's different regions, like there's sort of like congressional districts. States are broken up into different geographic sections, and your rates can vary, if you're in region 1 versus region 2 and so on. And in most states, they did allow one medical health related variable, which is smoking. They can charge you up to 50% more if you're a smoker. However, again, there are some states where they actually can't do that, where it still has to be the same for everyone. And then there's somewhere it's like 35% instead of 50. But in most states, they do allow for that surcharge. But that's it. They cannot vary the price or charge you more based on anything else beyond those 3 things. Third thing, essential health benefits. The healthcare policies have to actually cover healthcare. They have to cover things like, ambulatory services, emergency services, hospitalization, maternity. That usually wasn't covered in a lot of pre-ACA plans. Maternity, newborn care, mental health and substance abuse, those usually weren't covered. Prescription drugs a lot of times weren't covered. Lab services and so forth. So basically it was a list of 10 essential that have to be included in what you would assume would be. Then they added a minimum actuarial value, and that's what percentage of, so they have to cover all this stuff. What portion of it do they have to cover, right? They could say, well, we'll pay for cancer treatment, but maybe they only cover 10% of it and you have to pay 90%. Well, if that's $1 million, that doesn't do you any good. So it's broken into, they're labeled as metal levels, bronze, silver, gold, platinum, that cover roughly 60, 70, 80, or 90% of your typical expenses. And that's in the aggregate. That's not you specifically. That's, there's an aggregate enrollee way that that's calculated. The plans generally have very low premiums, but they have a very high deductible. Where you could have to pay $10,000, $8,000, or $10,000 before most services are covered. Platinum is the opposite. They have very high premiums, but very low deductibles, or maybe none at all. They might have zero. And then other cost sharing as well. Then I mentioned annual and lifetime benefit caps. Those are gone. You rack up $10 million in medical expenses, they got to pay, if they're supposed to pay for all 10 million, they got to pay for all 10 million. There is, however, a maximum out-of-pocket ceiling, or MOOP, maximum out-of-pocket. That is, you've got to pay your premiums, and then you'll have, whatever your deductible is, whatever your copays are, but only up to a certain point. So as long as you stay in network, as at the hospital and the doctors and the drugs that are all covered within your policy, if you have a catastrophic event, you get hit by a bus or whatever, and you rack up $1 million in expenses, the most that you'll ever have to pay, as long as you're within network, is, I think it's around $8,500 a year, or something like that, if you're single, and then up to, I think, $17,000 for a family. And that's a lot of money, but the idea is to prevent you from having to go into bankruptcy when you're insured. That's the idea. So there's a cap. So basically anything beyond that cap, the insurance company is supposed to pay for everything beyond that. Having said that, I mentioned deductibles. There are a whole bevy of no-cost preventative services included with every ACA plan. There's a long list. I'm not going to read them all, but it's, annual physicals, mammograms, blood screenings, drug screenings, immunizations. And this is where the coronavirus becomes very important, or the ACA becomes very important to it. When the vaccine comes out, hopefully soon, it should be covered at no charge, because of that requires, as long as the immunization is categorized as, in the same category as measles, mumps, and so forth, which it would be, then yeah, you don't have to pay anything for it, out of pocket, that is. So those are services where there's no copay, no deductible, no nothing. It's covered, period. And then finally, the one that turned out to be one of the most popular provisions is staying on your parents' plan until you turn 26. I don't think people thought it would be such a big deal at the time. It felt like sort of a throwaway thing at the time, but it's actually proven to be very, very popular and thing, especially for like college kids and stuff. So that was added. Now, when you add all those things, what you have is a one-legged stool, right? This is all the stuff. All these blue items, these are all the things that the insurance companies are required to do, or to include. When you do all that, needless to say, the price goes up, right? Every one of these layers adds to the cost and so forth. And if you have a one-legged stool, that's what, there were a couple of states that tried doing this back in the 90s, New York and Washington State in particular. They added guaranteed issue, and New York also added community rating, where everybody pays the same. The problem with that, if you just do it that way, is it led to a collapse because of something called adverse selection. Basically what happened was the sick people will sign up, and the healthy people won't sign up until they get sick. And as a result, the premiums go through the roof, which causes more healthy people to drop their coverage, which causes, premiums to go up further, and so forth. So that's called the death spiral. Basically, the stool. There were some big articles. This is from Noam Levy back in 2010, just before the ACA went into effect, talking about New York. the state became a victim of dangerous dynamic, laws allowing to consumer to buy insurance at any time. Basically, if you're healthy, you're young, you're healthy, you think you're invincible, and you decide, well, I don't want to pay, you know, $200 a month or whatever it is for your insurance, so I'm just going to go without any coverage. You won't get covered until you get diagnosed with cancer, or, you know, you get hit by a car or whatever. And then you say, oh, well, now sign me up. So it caused premiums to skyrocket. And at the time, just before the ACA, the New York, this is for the entire state of New York, not just the city, their individual market had dropped to 17,000 people. For comparison, 17,000 people is roughly the individual, that's smaller than the individual market today of Vermont or Wyoming. Okay, so the entire state of New York, only 17,000 people were enrolled in individual market plans because the premiums had just gone through the roof. There's another story from 2012 from Washington State, basically talking about the same situation. And again, as I mentioned, it's why, you know, you have to buy car insurance, auto insurance to, you know, to get to drive a car, and why you cannot get a mortgage unless you have homeowners insurance. That's the idea, is that you don't wait until your house catches on fire before you enroll. And that's actually a good parallel, because almost every state requires you to have auto insurance, except for Virginia. If you don't want to buy, you don't have to buy car insurance, but you can alternately pay $500 fee. That basically amounts to the same thing as the individual mandate for health insurance. That was the idea. So yeah, there's the death spiral. So, remember this guy, Mitt Romney, right? He was governor of Massachusetts. The state legislature, they passed a bill, it came to be known as Romney Care, even though my understanding is that he really wasn't a fan of it, but he signed it and took credit for it anyway. In Massachusetts, they designed the whole thing as a three-legged stool. And the idea was, first, you had everything I just listed, the carrier responsibilities, all right? Guaranteed issue, community rating, health benefits, actuarial value, no lapse, maximum out-of-pocket costs, free preventative services, standard plan until 26. That's all the stuff that the carriers have to cover. But they decided that they needed a carrot and a stick to keep that market stable. The stick is the enrollee's responsibilities. And that basically consisted of two things. The limited time open enrollment period, which we're in right now, from November 1st until December 15th in most states. There are some states where it goes longer, but basically you have a limited time window. You can't just waltz in any day. In most cases, you have to, you know, you have to sign up for next year. You have to sign up between, there's about a 6 or 7 week period. That's one. And that's actually pretty common for most employer plans. If you want to change your plan, you know, at your company, they usually give you just a few weeks around this time of year if you want to switch plans. Same thing with Medicare. If you want to switch your Medicare Advantage plan, I believe there's only a limited time window, and it's the same rationale, is to prevent, you know, people from gaming the system or whatever. The big one, which caused all the controversy, was of course the shared responsibility provision known as the individual mandate penalty, which is basically, if you don't enroll and you don't get an exemption for whatever reason, then you have to pay a fine, you have to pay a fee, you have to pay a penalty. The Supreme Court said it was a tax. That's how they made it. That's how they decided it was constitutional, was that it's a tax as opposed to a fee, I believe. That's what they called it. That's the thing that everybody hated. This is a thing that back in 2010, 2009, 2010, that the Tea Party rebellion, all that, that was one of the things that they were furious about, was, you know, the individual mandate penalty. Even a lot of people who supported the law otherwise didn't like that. It was very controversial. The limited open enrollment period, it used to be 3 months. It's been slashed in half to about 7 weeks in most states. There are some where it still continues out until the end of January. And then you have the third leg, is the green leg. This is the carrot, which is government's responsibilities, which is basically money, financial aid, the premium tax credits if you were in between 100 to 400% poverty, cost sharing reductions. That's for things like deductibles, you know, deductibles, co-pays, and so on. If you were in between 100 and 250%, And then having a level playing field, which is the actual exchange websites, healthcare.gov, covered California, the Massachusetts Exchange, Maryland, Connecticut. They all have, a lot of the states have their own exchange. It's basically a level playing field where you can review and compare, the different plans. And the idea is supposed to be that every plan offered through that website is fully ACA compliant. You don't have to worry about crap. You don't have to worry about junk plans, et cetera, et cetera. They're all supposed to THX certified, I guess you'd call it. And that's also how you qualify for subsidies, is if you buy through the exchange. And then something that a lot of people don't know about called the MLR rule, or medical loss ratio, which requires insurance to have to spend at least 80% of your premium dollars on actual healthcare, on actual medicine. So they have a 20% gross margin, out of which comes overhead, operational expenses, advertising, all that. The idea is to try to prevent or at least minimize price gouging. If they fall below that 80% threshold, it's a 3-year rotating basis, they have to pay the rest back. They have to pay the difference back to the shareholder, or to the policyholders. So in fact, I received a check myself for a couple $100. It wasn't much, but it's something. There are some people who have gotten thousands of dollars back basically because they overpriced. So as I said, the premium tax credits between 100 to 400%. If you're single, that's between around $12,000 and $50,000 a year. Family of 4, it's between around $26,000 and $104,000 or so. Cost sharing reductions, that's between 100 and 250% of poverty, up to around $30,000 or around $65,000 for a family of 4. The exchanges we mentioned, there were 13 of them last year. This one lists 12. But last year, Nevada actually split off of the federal exchange at healthcare.gov onto their own exchange called Nevada HealthLink. And then this year, there's 2 more states have split off of the federal exchange, New Jersey and Pennsylvania. So what's been happening is basically, as the last few years, more and more states have decided that they prefer to actually operate their own ACA exchange instead of using sort of the mothership. And in fact, next year,
can I add something
Sure.
in there about the Nevada decision?
Oh, sure.
Yeah, it was also right after the shock of the under-resourcing for people to actually get on the exchange, which had very real effects in our state. And I think that weighed heavily. The idea had been floated before, but I think that the ACA sabotage of the national healthcare system process clearinghouse, that was the death of it for Nevada. So it wasn't a distaste for what was on the exchange, but really the way that the exchange was not functioning.
Yeah, there was. Yeah, I mean, there were definitely. Yeah, there was a lot of reasons for it. Definitely, that was one of them. And tied to that was also the fee that the federal exchange charges. Because in order to operate healthcare.gov, they charge a fee to the states, and that fee it stayed exactly the same for years, even though enrollment grew and the costs, like the startup costs, of course, are expensive, but after that, it was amortized, and it didn't really cost that much more to keep running it every year, but they kept the fee the same, even though the premiums kept on going up. So yeah, Nevada basically decided, we can do this ourselves cheaper. And so they did. And the same thing with New Jersey and Pennsylvania. That's another one of the reasons as well, is basically they can save money, and they can use the savings either to shave off a point or two to the enrollees, or to use that savings to basically turn that around and use that money that they save for, in order to cut costs in other ways and so forth. So yeah. And in fact, next year, Kentucky, which famously or infamously, they had one of the best exchanges, one of the best state exchanges the first couple of years of the ACA. It got rave reviews, everybody loved it. And then Matt Bevin, the new Republican governor, he came in, and the first thing he did was he shut down the Connect Exchange for no particular reason that anyone could justify. But now, with the new governor who replaced him, it's Andy Bashir. My understanding is that they're bringing it back again. They're going to unmothball Connect starting next year, I believe. And Virginia is also supposed to be setting up their own, and I think Maine and Kansas may as well. So we'll see. Anyway, okay, so that's the three-legged stool. I mentioned the MLR, the 80-20 MLR rule. 80% has to go. That has returned a lot of money. 1.3 billion between 2011 to 2018. Over 770 million was returned last year alone. And this year, over double that. $1.7 billion is being returned to ACA enrollees this year. They overshot massively over the last couple of years, and so they have to pay the difference back, and that's what it's supposed to work. That's what it was supposed to look like. This is the three-legged stool as it was designed, or as it was intended. Unfortunately, it hasn't quite worked out that way. There's some major problems. First of all, the subsidies simply aren't generous enough for a lot of people, and you also have that 400% cutoff point, which means that if you earn even $1 more, it doesn't just taper off, it drops off to nothing, and you have to pay full price, and for some people that's just crazy expensive, right? This is an example, I think it's for like a 40-year-old or something in Virginia. Basically, if you earn below 138% of poverty, you're on Medicaid. If you're between 138 and 400%, you get the subsidies that keep, this is your percentage of your household income. It caps out at just under 10%. It's on a sliding scale. The problem is once you hit just over that, boom, shoots up dramatically. In this case, over 16% of your income. In some cases, it's even higher. And then it gradually drops off after that because as you earn more money, but yeah, that can be a hell of a sticker shock for this sort of 400 to 800 range, let's say. That's problem number one. And this is what most of the complaining in the early years was really about, and still is this is called the subsidy cliff, because that's exactly what it is. As a result of this, millions of middle-income people who can't afford paying full price dropped out, which again tends to cause premiums to increase more for everybody else and so forth. It hasn't been quite a death spiral, but it's been like almost sort of hovering right above that. Second problem, similar problem, is basically the CSR, cost sharing reduction. That program also should probably be beefed up more as well. There's a lot of people where the deductibles and copays are still, crazy expensive. It's actually a really good deal up to 200%, but between 200 and 250, it gets really stingy, and then over that, again, it just cuts off completely. So that should probably be beefed up. The third problem, this is where I get into I catch a lot of heat from people on the left side of the aisle. The individual mandate penalty, in my opinion, was never strong enough to be as effective as it should have been. If the idea is to, goad people into buying something, or they have to pay a financial penalty, the financial penalty was $700 per person, or 2.5% of your income. But the thing is, if in your head, if you think that $700, if you don't think the insurance is worth anything to you, then paying $700 instead of paying a couple thousand dollars, for the policy is going to seem like a better deal. So some people would just pay and go without. So I'm not saying that we should have the penalty, but if you're going to, then if you look at other countries like Switzerland, where they have a similar system, they have like crazy draconian. I think it's like $10,000 or something, and they'll garnish your wages. Like it's really, really hardcore, and it works, but. But that was one issue. Third problem is the maximum out-of-pocket cost or cap. I mentioned it was around like $8,000 for single, or like $16,000, $17,000 for family. The problem with that is if you are in a one-time catastrophic event, you know, you get hit by a car or whatever, that's great for saving your, you know, stopping you from going bankrupt if that only happens once. The problem is if you have a chronic condition, you know, where you're racking up tens of thousands of dollars every year continuously, then, you know, being told, well, you have a cap of $8,500 per year, or, you know, $17,000 per year, that's you can still go bankrupt that way. So that really should be dealt with. And yeah, 17,100 for family. And then this is a new one. I actually should have included this as one of the blue leg things, but it's sort of a little different, which is the network adequacy. Basically, in using this metaphor, this up at the top, this is basically the breadth of your network. How many doctors, how many hospitals, you know, prescription drugs are covered, are in network, right? And the problem is that the network adequacy rule of the ACA is unfortunately kind of weak. It's left a little bit too vague. I looked it up. This is from the American Medical Association. They wrote a thing about this in 2015, where they basically said that the ACA, it doesn't give specifics. It basically says that the policies have to have networks that are sufficient in number to provide services that are, you know, accessible without unreasonable delay. But it doesn't say what that is. It doesn't say you have to have the hospitals in, you know, within a 5-mile radius, or, you know, so many doctors with this specialty. It's very vague, and there's other requirements as well, but yeah, there's a lot of problems with that. It's sort of left vague, up in the air, and so that needs to be pinned down a lot. There's some issues with that. So this is really what the stool actually looks like, or this is what it actually looked like before the Trump era. Mostly in place, but there were some real problems. And you notice most of these are not due to sabotage. There's been a lot of sabotage, but most of these are, you know, there were some pre-existing problems with the ACA. And even as a huge fan of it, I fully admit that. Now, to me, the solutions are pretty obvious. Number one, eliminate that, kill the cliff, get rid of that 400% cap, and beef up the formula underneath that. Goes from this to something more like this, where this is the blue line. This is the formula where basically it cuts off at 8.5% of your income on premiums, regardless of your income. And again, eventually, you know, once you get up into the around 800% or so of poverty, it does taper off at a certain point, but basically no one has to pay more than a certain percentage regardless of their income. Number two, something similar with the CSR formula. Either beef up the formula itself, or you would upgrade the benchmark plan, which is currently, the benchmark plan, that's the policy that the subsidies are based on. It assumes if you were to buy the silver plan, here's how much you would get in subsidies. If you upgrade that from silver to gold, then basically you're getting a much better policy with a lower deductible, but you still get the subsidies based on that. Joe Biden's Biden Care Plan, that's part of his, but both of those are part of his proposal, that 8.5% cap, as well as upgrading the policy from silver to gold. And anyway, so this just gives a rough idea of the type of savings. This would be for a single 60-year-old with no children. Let's say at full price, they would be paying almost $1,000 a month for a silver plan, or $1,100 for a gold plan. Under the current policy, they'd be fine up to around $50,000 a year, but then you see it just over doubles to full price because of that cap. And then the deductible, is up to $4,500. Under Biden's proposal, those both drop dramatically. They don't hit full price until they get into some pretty decent income. The deductible is basically lopped down by 2/3, and so they'd be saving almost $10,000 depending on their income and so forth. So that's number two. Number three, if you had the individual mandate still around, would be to either increase the amount of it, which would piss off everybody. It's never going to happen. They're never going to bring it back anyway, I'm pretty sure. Or you could do something that Maryland thought about doing a couple of years ago, which is to make, instead of just paying a flat out tax to the government, that penalty, that $700 penalty, would be automatically put forward as to pay for, to enroll you in a bronze plan. Basically, you would be auto-enrolled in the least expensive policy, and that would go to pay for your premium, part of your premiums. That way you're covered without having to pay, you know, it's basically a way of encouraging you to be covered anyway, because that's the real goal of it, is to get everybody covered. Number 4, rework the maximum out-of-pocket formula. Unfortunately, that's an area I'm not a big expert on. Somebody here might have a better idea about how to deal with that. And number 5, basically codify the network adequacy requirements. Again, that's not an area that's really my area of expertise. I don't know if you could, you know, lock in, you have to have so many providers, so many doctors. I don't know if that's even feasible. Maybe require all the plans to be PPOs instead of HMOs. I don't know. But so if you deal with all of those, then you're back to what it was supposed to look like in the first place. And my guess is that if that was all done, that something like 70 or 80% of the complaints people have about the ACA would basically dry up. Not all of it, but a big chunk of it. So this is what it looked like before Trump administration came along. Here's what's happened over the last 4 years. Some very strange things. First of all, CSR, cost sharing reduction payments, were cut off. They were cut off to the insurance carriers, not to the enrollees. The CSR subsidies work differently than the premium subsidies, and it gets a little wonky, but basically due to a lawsuit that dates back to 2014, Donald Trump had the ability to cut off the policies. Do you remember in 2017 when he kept on threatening to blow up the exchanges? I'm gonna blow it all up. I'm gonna explode it. I'm gonna destroy it. What he was talking about was that he was going to cut off these payments. However, because of the weird way that they work, it actually, something very strange happened. Basically, the carriers were owed several billion dollars per year in reimbursements. They would cover the costs for a chunk of the costs for their enrollees, and in return, the government would pay them back. Donald Trump cut off the paying them back. Basically, he started stiffing the contractors. So what they did instead was, the assumption was that if they did that, that all of them were going to bail. They were all going to drop off the exchange and the ACA would collapse. Instead, what they did was something called silver loading, which is they took that money that they were losing, that reimbursement money, they figured out how much that was going to be roughly, and they just added that to their premiums. So they just raised their premiums by roughly the same amount that they were losing, so that, you know, they got their money one way or the other. But what they did was, in most cases, is instead of just raising the price on every policy by like 10% or whatever, or 20%, they dumped all of it on the silver plans only. So bronze would go up the normal amount, gold, normal, platinum, normal, silver would go up the normal amount plus whatever this missing money was. Which means that you got some really weird things that happened. You had cases where the silver policies, the official price, became higher than, or almost as much, or even higher than some of the gold plans, even though the silver plans had much higher deductibles. You had, and because, remember I mentioned that the premium subsidies are based on silver, that means that if you, let's say the premiums for bronze, silver, and gold are 300, 500, and 700, right? Let's say you're eligible for $300 a month in subsidies on a silver plan. You could buy a silver plan for $200 net. You could get a bronze plan for free, you know, basically zero premium, but with a huge deductible, or you could get a gold plan for $500, right? Now, if you're CSR eligible, you have to buy a silver plan to get the CSR help, so you would stick with silver anyway. But let's say that they dump all of it onto silver. Suddenly you got bronze 300, silver 700, and gold 700. A silver plan now costs as much as a gold plan. So the gold plan just became a much better deal because it has almost no deductible. If you're CSR eligible, you would probably still stick with the silver plan because it basically, you know, still wipes out most of that deductible. But let's say you earn enough for subsidies, but not enough, but too much for CSR. Well, all of a sudden, you've just got a nice bonanza, and you can get a bronze plan for free or a gold plan for dirt cheap. And in some cases, you can actually get a gold plan for free. There are several million people, I believe, this year who are eligible for a zero premium gold policy, which is a very, very good deal. Because of the weird ass backwards way that the whole thing works, there's some incredible deals out there for a lot of people, most of whom don't know about it. So basically, this is called silver loading, and it sort of mitigated the damage in a weird sort of way. There are still some people who got hurt by it, but I think more people are benefiting, so it sort of backfired on him. He was trying to destroy the ACA, and instead he kind of inadvertently helped it a bit. It's weird. But then, then, of course, December 2017, the Republicans in Congress, they passed their big fat tax cut bill, and as part of that, they zeroed out the individual mandate penalty. And this is very important for the lawsuit that's being discussed tomorrow. Because, well, I'll get to that later. They did not get rid of the mandate penalty. They just changed the amount from $695 to zero, and from 2.5% of your income to 0%. But they left everything else the same. And so basically they cut off the red leg here, or most of it. Well, that caused, remember I mentioned earlier about adverse selection and such, they thought that might cause it to collapse, but it actually didn't, or some people thought to skyrocket, but what ended up happening is basically what I call the world's most expensive shim. A big fat stack of money replaced that red leg in the form of additional subsidies, because the premiums went up around, by my estimates, around 6 or 7% because of the adverse selection factor. So premiums went up 6 or 7%, but you had a good 10 million people who were subsidized, which means that their subsidies just went up 6 or 7% as well. That comes to around $5 billion per year in federal money that's going to pay for the additional premiums caused by them eliminating the individual mandate. Not to mention, they also lost the income from people paying the penalty. And I don't know how much that is, but I assume that's another billion or so or whatever. So basically, they just shoved a big fat $5 billion shim underneath the stool to keep it propped up. So that's what happened there. Then there's some other stuff they've done. They tried to mess around with the formula, the subsidy formula a bit, which shaved off. It basically made the subsidies less generous. They've been pushing hard for third-party web brokers for people to buy through, to not go through the official exchanges, but go through third parties. Some of which are okay. There's one in particular, I'm not going to mention their name, but because they advertise on my site, so I don't want to give them too much free rein. But there are some which are fine, but there are others which also, they basically intermingle official ACA plans with short-term plans and non-compliant plans and such, which confuses the issue. It basically gets back to it defeats the whole point of having the exchanges in the first place, because it confuses customers and so forth. They also, Seema Verma, the CMS administrator, a year or so ago, she issued a new statement about what's called a Section 1332 waiver rule. Basically what that is the ACA includes a section called Section 1332 of the ACA, which allows states to experiment. It lets them play around with the ACA. The idea was supposed to be that if they could find a way to cover at least as many people in their state with at least as comprehensive coverage without increasing the federal deficit, right, without costing the feds more, great, we'll do it. We'll okay it. You have our blessing. And so they have to prepare a whole paperwork, a whole plan, and they submit it, and they're supposed to be able to prove how this is going to help and be a better way of doing things. But there are certain rules, there are certain guardrails. Again, it had to cover at least as many people, at least as comprehensively, without costing many more. Seema Verma played around with that, and she basically weakened she went around the edges. And the net result of this is that last week you may have heard Georgia, just before the election, the state of Georgia was approved for their new 1332 waiver request, which basically allows them to opt out of healthcare.gov altogether. And I don't mean they're going to move to their own based exchange. I mean they're just going to not have an exchange at all. It would be right back to going directly to the brokers and to the private brokerage websites and such, where they can hawk their wares, they can hawk whatever they want to sell, and essentially the idea is that subsidies, the federal subsidies that are supposed to only go to fully ACA compliant plans, would presumably be going to these short-term plans and other non-compliant plans as well, which completely defeats the point of the ACA in terms of consumer protection, in terms of subsidizing junk plans, and so on and so forth. Now that doesn't go into effect until 2023, and of course now Joe Biden just won the presidency, so I'm hoping that his HHS secretary, whoever that is, will put a stop to that before it even starts. But that's the sort of thing that they've been messing around with. Anyway, that finally brings me to the lawsuit. And I don't know if is Nicholas Bagley still here? I saw he popped in. He is.
I'm still here. Yeah.
You're here. Hello. Welcome.
Good to see you, Charles. How are you doing?
Okay. Thank you for joining us. Thank you for staying this long. Sorry it took so long. I talk a lot.
It's a complicated law.
Should I give a little backstory first and then turn it over to you, or?
Sure, whatever you'd like.
Okay. So yes, the lawsuit. It was originally called Texas versus Azar, I think. And then
Texas versus United States. Sometimes people call it Texas against Azar. The label is not what matters.
Yeah, they keep changing the name, and now I think now it's officially California versus Texas.
Mm-hmm.
Anyway, so the basic idea of the lawsuit is this. Remember, in 2017, December, the Republican-held Congress, they eliminated the individual mandate, or they zeroed out the individual mandate penalty, but they did not eliminate the actual language underneath it. And as a result, a few months later, Ken Paxton, the Republican Attorney General of Texas, got together with 20-odd other Republican attorneys generals, and they came up with this lawsuit that claims, and correct me if I'm wrong about this, they changed the shared responsibility penalty, the mandate penalty, from $695 or 2.5% of income to 0 or 0%. In 2012, the Supreme Court ruled that the mandate penalty is only constitutional because they declared it to be a tax. They're claiming that a tax of $0 is not a tax. And that because of that, as they claim, therefore the mandate penalty is no longer a tax, therefore the mandate penalty, that the mandate is no longer constitutional, therefore it has to be struck down, and that the mandate is inseverable, cannot be separated from the rest of the law for reasons. Therefore, the entire ACA is no longer constitutional, and therefore the entire ACA must be struck down. All of it. Whole thing. Even the parts that have nothing to do with the exchanges or any of that, they say the whole thing has to go. Do I have that right?
You have that right. And I have to tell you, I'm so sick and tired of trying to describe this case because the argument is so nutty that even by describing it crisply and cleanly, you give it more credit than it's due.
Well, I simplified it even further.
Sorry, this is Maya. Can I just interrupt for a sec? I actually don't, I follow this pretty closely. I'm actually a doctor myself, but I don't feel like I understood all of the steps, even if they are stupid, that they're going in order to argue this. Do you mind just repeating that? And I'm really sorry to interrupt.
No, I'm glad.
Well, Charles, let me try it, and then hopefully if you do it one way and I do it another way, it'll sort of all come together. So the idea is that in 2012, the US Supreme Court said there's this individual mandate on the books, and it says, thou shalt buy insurance, and if you don't buy insurance, you have to pay a tax penalty. And the Supreme Court said, if you read the mandate to be a coercive command, it's unconstitutional, but we're going to read it as giving people a choice. They can either buy insurance or they can pay a penalty. And that saves the constitutionality of the law. You fast forward to 2017, and Congress decides to zero out the tax penalty. And you might have thought that by eliminating the only mechanism for enforcing the individual mandate, that you made it less coercive. And that's in fact what everybody thought. They were repealing the individual mandate, and Trump said as much, and every congressional Republican to vote for the law said the same. Nonetheless, the challengers here say, hey, they got rid of the penalty because they moved via reconciliation just to eliminate it, but they left this language on the books that says thou shalt buy insurance. And it can't, that language can no longer be understood as a choice, as giving people a choice. It's just a command. And it's the kind of command that back in 2012, Congress said was unconstitutional. That's the argument about on the merits. And then they have an additional argument about why the problem with this toothless mandate requires pulling down the rest of the law. But that's like another long, complicated explanation.
So even though that's stupid, I mean, I'm not aware at all. So is there like some sort of logic to that if a tax of zero isn't a tax, then you can make this argument? I mean, like, is this?
Yeah, I think if I was going to put the argument in its best possible light, what you would say is, the statute says individuals shall buy insurance, and shall means shall. And the job of a judge is not to look to what Congress meant, what its purpose was. The job of Congress is to enforce the law as written. And even if the law has no enforcement mechanism, shall means shall. That's the argument that the lower courts all accepted.
But what about legislative intent? I mean, that's the big, legislative
Yeah,
intent
there are a
is
lot of problems with the argument. I mean, even as a textualist matter, the argument doesn't work. But the notion that Congress in 2017 made the law more coercive by getting rid of the mandate penalty is a completely goofy argument. And I think it's one that's going to give the Supreme Court some pause.
There you go.
Thank you. That was helpful.
Yeah, and as Nicholas, do you go by Nicholas or Nick, by the way?
Nick.
Nick. Okay. As Nick also noted, the other, and you notice I have the question marks there as well. There's also, as he's pointed out, the question that a tax of zero is not a tax. There are plenty of taxes where you don't pay anything, but it still exists. It's just that the amount you pay is zero, right? And then also this whole thing about the severability. That's the other like big thing is that the fact that why can't it just be just chop that out and leave the rest? Like it's one sentence, right? Like why can't they? And there's like I don't think there's any logical reason. That I think, and correct me if I'm wrong about this, Nick, that the argument is that because the Obama administration in 2012 claimed that at that time it was vitally important to have this penalty, that therefore today, 8 years later, that it must therefore still be absolutely vital. But that doesn't make any sense because clearly it is not vital, because the law is still around. There was no penalty paid. What happened? The only effect of it, the only real world effect of it was, as I said, premiums went up about 6 or 7%, and most of that's actually had to be paid back because of the MLR rule anyway. So like, the adverse selection was not nearly as bad as they thought it was going to be. So basically, you could argue I would say there are two arguments. First of all, they could have just been wrong. You know, they thought it was vital. It turned out it wasn't. You know, they were wrong. That's not a crime. You know, but the other being vital in 2012 when the law was just getting started and it hadn't even, you know, the exchanges hadn't even launched yet. They wouldn't for another year and a half, is not the same as being vital 8 years later. At the time, the insurance carriers, it was a whole new world. It was a whole new thing. They didn't want to take a bath, right? They didn't want to take a huge loss. So the insurance carriers put them under pressure. Plus the Massachusetts model that it was based on, you know, there was a mandate penalty there. So the assumption at the time was by everyone involved was we have to have some sort of an incentive, some sort of a penalty. You know, again, the carrot, you have to have a carrot and the stick. And if you don't have the stick, then that's going to cause a death spiral and, you know, premiums to go crazy. And so, you know, they based that again in New York, in Washington, as I mentioned, where they saw that that's what had happened. So they assumed, you know, so at the time, if they had not included that, there's a very good chance that none of the carriers would have participated at all. They said, well, forget this, we're not going to do this. And then there wouldn't have been so that it would have been destroyed. Well, it's 8 years later now. And clearly there was a lot of rocky road in between, but the exchanges are still around. The carriers are actually expanding their participation. You know, they were dropping out for a couple of years because it got bad, but then they've turned around and now they're actually expanding where they're covering. It's working. It's clunky, but it works. And so saying that, you know, even if it was vital then, that doesn't mean that it's vital now. It damaged it a bit, it dinged it, but it didn't destroy it. So.
Yeah, that's exactly right.
So
I mean, a later
compelling...
Congress.
Sorry, go ahead.
Oh,
I was just wondering what the.
Sorry, you go ahead this time, Julie. Sorry about that.
Okay, sorry about that. I'm just wondering then what was compelling to the lower courts about this severability question, if that's what those decisions, I haven't read those decisions, so I don't know what they relied on. But.
Yeah, so I mean, I think I'm going to offer you the reductive but true explanation, and then I'll walk you through the law. The reductive but true explanation is that the district court judge who heard this case is a partisan hack. And, you know, there's just no two ways about it. A known partisan hack, and the reason that the plaintiffs filed in Fort Worth, Texas, is because they hoped to draw him as their judge. They knew he was in the tank for them. The doctrinal reason is that severability doctrine is pretty slippery. And the way you understand why you can understand how it's slippery is that if you've got a big law and there's a small, the temptation is to think you can just pull that one small part out of it. And that's probably the right approach most of the time. But sometimes that little part interacts with at least some other parts of the big law, such that pulling it out would leave this kind of maimed law behind you, something that no one would ever have voted for and something that works less well than anybody would have endorsed. And so what the courts have come to is to say, look, when there's a constitutional defect in part of a law, you got to get rid of the individual part, and then anything that's like so related to it that it kind of, they're all bound up as part of the same broad scheme, such that you can't eliminate that part without sort of warping the rest. Now, you might think that if you engaged in that kind of severability inquiry, save as much of the statute as you can, but just get rid of the parts that are tightly bound up and the defective part, you would just strike the language saying, thou shalt buy insurance, and we'd be done with it. But the district court judge who heard the case said, well, you know, the individual mandate, you know, there are these findings in the law that say it's an essential part of the law, essential to guaranteed issue and community rating in particular. Congress didn't repeal those findings and therefore bound by what's in the law. And therefore, the individual mandate, you know, the guaranteed issue and community rating have got to go. And that means the individual insurance market reforms have all got to go, whether that's premium subsidies or cost sharing payments or the exchanges. And would Congress have wanted the Medicaid expansion to exist if the individual insurance reforms didn't exist? Well, no, those are all bound up as well. And so you get this analysis, this kind of, you know, like shin bone connected to the leg bone, connected to the thigh, you know, whatever, right? Like at the end of the day, he's like, I just can't figure out what Congress would have wanted. I'm going to strike the whole thing down and send it back to Congress for it to consider again. And that last move is very typical of conservative legal activists, the claim that they're not doing anything really extreme because Congress can always step in and fix it. But of course, as everybody on this call knows, you know, Congress doesn't act like that. It doesn't work like that. It's not easy to pass new laws, and the window for passing legislation opens rarely. So, a pretty mendacious decision. The case was then appealed to the Fifth Circuit, and the Fifth Circuit actually didn't resolve the severability question. What the two Republican appointed judges on the panel said is, we thought this partisan hack judge on the Texas district courts, we thought he took kind of a blunderbuss approach to severability. We think you could be more discriminating. There are these bits of the Affordable Care Act that require calorie counts on FDA nutrition labels. Those don't seem tightly bound up with the mandate. So, O'Connor, go back with a fine-toothed comb and decide which things really truly are bound up. We don't have any opinion. Maybe it is everything. Maybe it's nothing. We don't know. And that served as a kind of dodge for the Fifth Circuit to avoid wading into the decision in the midst of an election year, and to kind of punt the question for quite some time to come. The Supreme Court, probably the four liberals in the Supreme Court, decided to take the case anyhow, and basically called their bluff. That gambit doesn't look as smart in retrospect, given Justice Ginsburg's passing.
And so what's the posture of the case now at the Supreme Court? Are they looking at the issues that the circuit court, the trial level court looked at? I mean, essentially the application of law in that, in that context? Yeah,
so they're looking both at there are kind of three big questions teed up for the court. Do the plaintiffs have standing to sue? I suspect personally that that's the likeliest way the court's going to get rid of this case. Is this $0 individual mandate coercive, unconstitutionally coercive? And third, if it is coercive, does the rest of the law have to fall? And those are all strictly legal questions that are teed up for the court to resolve.
So what's your gut on where we are with this? I mean, I think we all are in agreement about what the rational decision would be, but what's your sense, especially given the new composition of the Supreme Court?
I'd be curious about Charles's views. My own view is this is a long shot lawsuit. The Chief Justice has turned away too much stronger challenges to the law, and Justice Kavanaugh has written extensively about the importance of salvaging as much of Congress's handiwork as possible when you go about constitutional analysis. So I think he's not going to be enchanted with this lawsuit either. It's hard to speculate about the internal thoughts of people I don't know real well, so I don't have a terribly high degree of confidence in that. But I'll also add that I don't think the Republican political establishment has done the work that they need to do to make this case seem plausible. I think even to people who are kind of in the tank for Republicans, I think even they think this lawsuit's kind of silly. Nobody's barnstorming the country doing town halls about the despotism of the individual mandate. Mitch McConnell has sort of damned the lawsuit with faint praise. Republican office holders are running away from it as fast as they can during elections. And all of that matters in constitutional litigation. I think the Republican justices don't have kind of a lot of public support here. And that matters on the margins. So, I think it's a very small chance, but, a small chance of a very bad thing is something worth worrying about.
Yeah, and I just, if I could boil the case down even further, I would say it boils down to this. Because we cut off this, we get to destroy the rest of it. Like, that's it. That's basically that's the justification. And that ties into something that Nick and I have talked about, on the side, which is, this is where you get into a very weird messaging thing. And this is for, those of you who are talking about this. I mean, I don't know. You tell me whether, I'm assuming that the Supreme Court justices do not spend a lot of time on Twitter, but maybe they do. I don't know.
At least some do.
But when the lawsuit first came out, almost nobody paid attention to it. Like I wrote a throwaway thing. I think it was like February of 2018, like 2 months.
Yep.
And I wrote a quick thing about, this is goofy, and that was it. And then it was like 6 months later was when you were like freaking out. That was when the point at which, here's the other thing about this lawsuit that I don't think people understand. And it's hard to remember, but there was a time in this country where the Justice Department was supposed to actually defend the law and the law of the land, and not, you know, the president personally. And Jeff Sessions was still Attorney General, and there was some sort of filing or motion or whatever you call it, some sort of development in the case. And the Justice Department basically threw the case. That was the point where basically they went in and they're supposed to be defending the law. You know, Donald Trump may hate the law. Jeff Sessions may hate the law, but he's the Attorney General. It's the sitting law of the land. They're supposed to defend it, right, in court. And so they went in to file, and instead they filed this thing that basically said, we're not going to defend it. And not only that, we actually agree with the plaintiffs, is what it amounted to, right? And I think there were a couple of judges, there were a couple of lawyers who actually resigned or at least stepped off the case or something because they wouldn't.
Yeah, Joel McIlvaine resigned. A couple of other lawyers took their names off the case. It was a very big deal within the Justice Department, which takes its commitment to defend acts of Congress extremely seriously. I served in the Justice Department for 3 years in the Civil Division, and it was kind of a bedrock principle that we all sort of cared a lot about because it's a fundamental part of what it means to live in a country ruled by laws and not by whim.
Right, and that in retrospect is sort of a precursor of things to come, right? But yeah, so basically, and that's where and Nick actually coined the phrase the Texas Hold'em is what he called it, and I've been trying to use that hashtag for a year now, and it doesn't seem, I seem to be the only one using it, but
yeah, I'll take one.
Basically they threw the fight, you know. And they didn't just throw the fight, they actually like helped the opponent, you know, they were helping the opponent. And that's the reason why, by the way, why the name changed, why it's now California versus Texas, because what happened was, if the Justice Department is not defending a federal law against a federal lawsuit, who is? Well, two parties tried, right? The House Democrats tried. They said, well, we want to defend it. And then a coalition of Democratic attorneys general, came in and said, we're going to defend it. And I believe they said that the House didn't have standing to defend it or whatever. But so what you end up having now is 20 Republican attorneys general versus 20 odd Democratic attorneys general defending the law. And in a couple of cases, the same, because some of the states flipped in 2018, like Wisconsin, I think Colorado maybe, where the Democratic Attorney General, you know, the Democratic candidate beat. So you had some states which actually flipped from being a plaintiff to being a defendant in the same case, which is crazy. But as a result, so now it's California versus Texas because California, Xavier Becerra, I hope I'm pronouncing his name right, he's the lead defense, right?
He's taking the lead, although I suspect he won't argue the case, yeah.
So the Attorney General of California, right? Versus the Attorney General of Texas. So that's the situation. And the problem is that when the story blew up, when it actually, you know, gained public knowledge, a lot of Democrats were like, of course, they meant to do this. You know, Republicans, this was a time bomb. They deliberately did this. They knew this was going to happen. And when they asked, like, a bunch of Republicans, you know, members of Congress and former members, because a lot of them lost their job right in the midterms, they were asked by reporters and stuff like, well, is that what you meant? And like every single one of them, even though these are Republicans who had just spent a solid year desperately trying to repeal the ACA, every single one of them was like, no, that wasn't in our heads at that time. Like, and people don't believe them because they're like, well, you just spent a whole year trying to kill it. Of course, that's what you were trying to do. They were like, no, that was like their consolation prize. You know, like we spent a whole year, we almost killed the whole law, but we didn't do it. And so like our consolation prize, well, at least we can get rid of that stupid mandate. And so let's just do that. And so they did. And so like in their heads, that was really, there was not a secret plot by, you know, Mitch McConnell and Lindsey Graham and all these. That was not like in the, we're going to kill the mandate and then wait, and then there'll be a lawsuit. That was, I honestly believe that. I don't believe a damn word that comes out of their mouth about anything else, but on that I believe them, that was not in their heads at that moment because it's such a ridiculous case, you know, that the logic is so, they couldn't possibly have fathomed that would, and I don't know if it was Ken Paxton or who actually came up with it, but someone at their end. So I think Democrats are actually, or people, you know, ACA supporters are actually, should not be sitting and saying, well, they meant to do that. Well, no, they really didn't. And when you say that, you're actually lending credence to their case because, as Nick said, the question falls on what was Congress's intent, so don't say that. So.
Charles?
Yeah.
Could both of you kind of talk a little bit about what the typical schedule of the court is? Because we are in the middle of open enrollment. And there are a lot of people who think that they shouldn't be, and I'm sorry, I came late, so maybe you talked about this already, but that they shouldn't enroll because there's not going to be a plan, and it's going to be ruled on next week, and it's going to be totally decided, and there's not going to be any insurance. And that's absolutely not true. And one of the biggest messaging things I'm trying to fight right now, and a lot of us are, about we need even more than ever to have a strong enrollment period. Now that we have a new administration coming in, of course that's beneficial, but we still need to prove how critical the ACA is to so many people.
Yeah, and I mean, so the number one thing that I've been trying to get through people's heads is the hearing is tomorrow. That does not mean the decision is tomorrow. And I've checked with Nick on this. He says, and again, correct me if I'm wrong, that it is almost, that basically we're probably looking, like April or May of next year, most likely?
April, May, or June, yeah.
Or even June. That it's a big case, that you said, like, even for little cases, it usually takes, a while. They're not gonna do it 5 minutes, give their decision later. It usually takes a few months. And that you said that, like, for a really big, important case that affects so many people and so much precedent, blah, 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 that it's almost unheard of that it would be any less than like 6 months or so. Of course, there's been a lot of unprecedented things that have happened lately. Who knows? Maybe, maybe they'll end maybe it'll be 5 minutes after they're done, but it sounds like you don't think that's going to happen. So that's
that
really
won't
important.
happen.
And that now the fact that we're looking at between like April and June of next year is really important for a few reasons, some of which should be obvious. Number one, if the Democrats do end up with a trifecta, which is still possible, remember there are 2 Senate seats up for a runoff on January 5th. If the Dems win in both of those, they will have a 50-50 Senate plus Kamala Harris as the vice president, so it'll be a bare majority. Also, there's, I guess, the Alaska race. There's still a possibility that they might flip Alaska. So we'll see. That'd be great. So it's possible. If they do, then, and this is the thing that we were actually on. Nick has been saying this for like a year and a half now. I was hedging my bets until Ruth Bader Ginsburg passed away. If they have a trifecta, they can do one of 3 things before they can make the case moot before a decision is ever even rendered by passing a simple law. Number 1, they can pass a law which changes the penalty back up to something more than 0. It doesn't have to be the full $700. It could be $1, right? Anything over 0, which kind of underscores how ridiculous this case is. But that would instantly render the case moot, right? Number 2, they could issue a simple statement. I believe that simply they could just tack on a little line onto the ACA that just says, amend it, says, oh, by the way, the mandate is severable. It is not connected to the rest of the law. Or number 3, they could do a simple line thing that just strikes out the shall buy insurance thing. Like that's it. And I think these are all like 1 sentence or something, 1 paragraph. They could pass one of those. Now,
it would be a 1-sentence bill. It would be easy to do.
Yeah. Now, my understanding, now we get into things like reconciliation and the filibuster. As I understand it, the first one, changing the amount back to something more than $1, they could do with only 50 votes, but it would have to be done through reconciliation. And I guess that gets messy, and it would probably be done as more of like a larger budget. They're not going to waste the whole process on like this one thing, although maybe they should. So that's one possibility. The other 2, I guess, would require 60 votes unless they kill the filibuster. One of many, many reasons I think they should filibuster if they can, but so it's not quite that simple. But yeah, if they get a trifecta, it would buy them some time. So that's number 1, or number 2 rather. So it's not going to be decided tomorrow or announced tomorrow, and the whole thing could be made moot before next April or May. The other thing I would say is that even, let's say a worst case possibility, bite my tongue, knock on wood. Let's say a worst case possibility, it's April or May, let's say it's May of next year, and they do kill the law. You should still enroll. I mean, people are still only, they're still only liable for, through the point that their policy ends, right? So it's not like you have to pay for the whole year and then only get 5 months out of it. 5 months of coverage is still 5 months of coverage, so people should still get covered. Having said that, one thing that I am concerned about is that I was under the assumption that if they did issue, if there was a worst case scenario where they shoot down the entire law gets torn down, that they would put a stay on their decision until like January of 2022 because of the massive chaos it would cause. Nick was saying that actually they might, but actually probably not. And maybe you can speak more about that.
Yep. When the Supreme Court reviews constitutional cases, it views its role as saying whether the law is or isn't constitutional. It's not supposed to say when the law will or won't take effect. And so when it issues its decision, it's just making a declaration, and it doesn't monkey with the timing of that declaration. It used to do some of that kind of thing, but the last time it did so was back in a case in 1982. So I'm not holding my breath, especially because since then the Supreme Court has eschewed the kind of approach that it took in that case. So its decision would take effect pretty much immediately, and that would mean that the financing to support the Medicaid expansion and the individual insurance markets would dry up pretty much overnight.
So wait, I'm sorry. Wait a second. We're talking 20% of our economy. You're saying that you would see the Supreme Court issue, potentially, if they decide to do this, members of the court issuing a ruling that would attack 20% of our economy. The insurance companies would already be anywhere from 4 to 6 months into annual contracts where they're guaranteed money from the federal government, which a case was just ruled that when they were told we're supposed to get money back in the risk corridors, now they get the money. You could foresee this court issuing a ruling that would be that detrimental and not putting a stay on it until next January? Especially when the insurance companies at that point are already putting their rates together for the next year. I mean, I'm not, please understand, I hold you in the utmost, both of you, in the highest respect, but this is something that
in the middle of a pandemic.
I'm trying to, pardon?
In the middle of a pandemic too.
Right, in the middle of a pandemic. And, I'd like to think we're not that broken. I know we're broken, but that just, to me, and I know I'm sputtering because I'm really, really having a hard time coming to terms with that, because it would be essentially breaking our country even more. Yeah. You're talking.
Look, I'm with you.
Of our economy.
I'm with you. I think that there are a fair number of conservative jurists who have treated the litigation around the Affordable Care Act as a game to try to achieve a political objective in a domain they don't know much about and they don't frankly care that much about. I don't think the Supreme Court is going to strike down the ACA. I think it's very unlikely. And I think for all the reasons that you give, I think they sense that it would be many bridges too far, that they don't have the kind of public support they need, that it would be viewed as illegitimate, that they would lose a lot of stature, and that they would pitch a big part of the economy into a tailspin. But, I will say, I used to have a lot more confidence in that judgment before Justice Ginsburg died, before the lower courts sided with the challengers. I have less today. It doesn't mean I have none. I mean, I think it's like, a 5% chance or a 3% chance, or, that order of magnitude that this case really goes south. But if it does, it's going to go south in a big way. I mean, there's no halfway measure once you decide the Affordable Care Act is unconstitutional. Like, everything comes crashing down.
I remember
that's what's hard for people to understand. Yeah, because it's like the lower courts can issue stays, but that's not really That's not what the Supreme Court does typically. Right?
Yeah, I mean, it could. I mean, the Supreme Court can do whatever it wants with 5 votes. But I think that's pretty darn unlikely. Certainly no party in the case has asked for a stay.
When I remember reading, I was doing some research on the Manhattan Project a while back, you know, the development of the atomic bomb. And I remember reading somewhere that there was a group of scientists, very, very concerned scientists, that they sent a letter to, like, you know, the Pentagon and you know, the President, President Truman and so forth, in which they had calculated that they, by their estimation, they thought that there was like a 2% chance that exploding an atomic weapon and, you know, nuclear bomb would ignite the atmosphere of the planet, you know, and burn off the entire atmosphere and wipe out all life on Earth. And they sent this letter, you know, and apparently the powers that be decide, well, 2%, yeah, you know, we'll take our chances. And it turned out their calculations were wrong. There's too much nitrogen in the air or whatever. So they were wrong, but they didn't know that at the time. You know, at the time they basically, 2%, yeah, you'd have to roll a natural 20. You know, it's so yeah. I think that's kind of where you're coming from on this. Yeah, it's unfathomable, and there is, and the depressing thing too is another sort of negative thing on this is that I wrote about a week or two ago is the insurance carriers have a clause. They have basically an exit clause in their contracts with the federal government that allows them that if there's, you know, if the subsidies are cut off, or there's any, you know, if there's like, you know, significant changes, dramatic changes to, you know, their terms of their agreement, that basically they have the right to terminate policies immediately. And I mean, like that month, you know. So if the decision comes out in mid-April, then I presume at like the end, you know, like April 30th, they could, you know, kick everybody at the curb regardless. And now that's subject to state law, you know, breach of contract and, you know, things like that. So there's some states where, you know, maybe they could, some states maybe where they couldn't. It only applies to the states of the federal exchange, not the state exchanges. So there's a dozen states where that wouldn't apply. But that's small comfort, because all that means is that in those states, the insurance companies would have to keep you on your policy, but they would just start charging you full price, which, you know, for a lot of people amounts to the same thing, because, you know, they're going from full price to nothing. So, so Nick had to go, and I know that was a depressing moment to end on. I'm done with my little PowerPoint, and my voice is raw. Does anyone have any questions for me? Please
What's the best way for
unmute yourself
to make sure people get enrolled?
Well, you know, I'd say number one is, you know, pray that we flip Georgia. But in terms of enrollment, you know, open enrollment, you know, just a little shout out. Open enrollment is ongoing from now through November 5th or through December 15th in most states, through later than that in about 10 states, I believe. And visit the, well, you know, you can go to healthcare.gov, and even if you live in one of the states that runs their own exchange, if you plug in your, you know, your state, it should direct you towards, you know, Covered California or, you know, Get Covered New Jersey or what have you. So if you're not covered, get covered. Do not let yourself be auto-renewed automatically. Shop around and you do so. And beyond that, Miranda, if there's anything you want to say, my voice is going.
Well, I'd say that there's a lot of grassroots organizations working on enrollment. Starting tomorrow, there's a Twitter storm held by Young Invincibles, Community Catalyst, a whole bunch of others about open enrollment. We have graphics on social media, both on the ACA Consumer Advocacy page, on both Twitter and Facebook, as well as the ACA Signups page, and floating around to help get people out.
This is my friend Miranda. I'm sorry, this is my friend Miranda Wilgus, who she runs ACA Consumer Advocacy, which this is their thing, is helping people get covered and get enrolled and so forth. So.
Well, and we're just asking everybody to help. I mean, I know Peter's been doing a really good job. You have been, but we need everybody in this because over the last 3 years, they've slashed outreach and education by 90%. And Thunderclap, it doesn't exist anymore. So now it has to be done on an individual basis. And we need everybody to utilize your networks to help get the information out. And to exactly what Charles and Nicholas were talking about, the ACA is not dead. I mean, that's the messaging I've been putting out for everybody. The ACA is not dead. The case will not be decided tomorrow. The earliest it should be decided, hopefully, is next year, next plan year. And these are annual contracts. So yes, there's some of the language, but there's also the contractual thing. And it is the middle of a freaking pandemic, and people have been losing their insurance because they're losing their jobs. So this really is the year that people need to make sure that they know, especially since there's been so much negative information and people just assume that the ACA is dead, and it's not. I have a graphic that makes it look like a Timex. It says ACA takes a licking and keeps on ticking. Get enrolled, and that's my big thing. Thank you, Charles. This was awesome.
Charles, this is Barry McEllison in Fort Worth.
Yeah.
Do you have a recording of this Zoom session that we can share on our websites?
I do. It's recording right now. This is like the first time that I've recorded something on Zoom, so I'll have to.
Okay, so you can share that link with us, and then we can pick it up and share it.
Yeah, I'll walk you through it afterwards.
It may end up being audio only, well, which wouldn't be much good.
No, it'll show the whole thing.
I know. I'm just not sure what the limits are on my account. Like, you know, they have a cap on how many gigs, and I'll take a look though. I'll see. Hopefully it'll be there.
I think it's the whole thing, and it'll be on your hard drive, and
but it's recording it to the cloud. So
yeah, right. So if you have a link to the cloud, you can provide that.
You can still download it to convert it.
Yeah.
I will see what I can do. See what I can do, and then what should I do? Should I send it to? Should I just post it in the? Trying to think what the best way to get it to the folks on the call.
Well, you have everyone's email address.
Yeah, I'll send out I'll try to send out an email to everybody and let you know, with a link.
Hey, Charles, I have a question on Part D. You'd said earlier you're going to come back to Part D. Real quickly, the Bipartisan Budget Act of 2018 supposedly closed the Part D coverage gap in 2019 instead of 2020 as per the ACA. Has that changed? Do you know?
You know what? Honestly, I don't know. I'm not.
Okay, I will drop a link to KFF in the comments.
Sure.
And there's a link. I know you're tired and worn out. And thank you so much. This has been very, very helpful.
Thank you. And Gary, I know you've had your hand up for a while there.
Oh, I'm not sorry. I meant to take it down. I was just asking about the dog.
What's that?
Oh, I meant to take it down. I was just asking about the dog.
Oh, Buddy?
Yeah.
Yes, Buddy the Wonder Dog. Yeah, he's not in here right now. I'm sorry.
So I want to say one more thing. One of the things I've seen resurging that we used to have a lot of was the continuity of care provisions, where when you enrolled in one insurance, they would ask you, which one you were enrolled with before, to try and see if you'd had a gap and suddenly now have an illness. And so they would use that to exclude or price you out or whatever. And now it's just kind of more pushing towards the regulations. But that continuity of care is really, really important, because a lot of people right now are defaulting to COBRA just to make it to the next offering or till things stabilize with the ACA. It's really important that people not fall out of coverage, because if the ACA falls apart, that could be by itself a pre-existing condition that they can use to exclude you. And I think that's not really communicated enough, because many people who are experiencing hardship with healthcare access now weren't doing so before the ACA, so they forget what it was like for all of us who had to deal with all those categories of risk.
Absolutely, and that's, and this is, and again, I don't want to end this call on like a downer note, but but it is, that is another important thing to get.
Good point.
People need to understand is, and let your networks, people you talk to, try to remember this. We're in a very different world now than we were 10 years ago. And I'm not just talking about the pandemic, and I'm not just talking about Trump or any of that. I'm saying there are some people who honestly believe that they preferred the prior, the system 10 years before the ACA. Why don't we just go back to exactly what it was back then? There may be downsides to it, but why don't we just do that and all would be well? We can't, even if we wanted to, even if everybody agreed that was a better thing to do, we can't. It's a whole different situation. And you just mentioned, you remind me, for example, social media. I mean, social media was around 10 years ago, but it hadn't taken over everyone's lives as it has now. If you go back to a time where you can be denied coverage or charged up the wazoo or whatever, based on just about anything, guess what? Most people's lives have been publicly, every time you went on you went on to a kegger, every time you went whitewater rafting, you did some dangerous thing. Every time you ate a fatty cheeseburger and posted a picture of it on Instagram, or whatever, or Pinterest, all of our lives are online. So insurance companies, they can just go through all that. They got your man. Not to mention, through things like, the audio, Siri and, Amazon Echo, all of those things where they record everything. Every time you order something online, your prescription online, all that stuff is out there, and nobody's cared. Nobody's thought about, I hope insurance company doesn't find out about this, because they didn't have to, because the ACA protected. The ACA they can't charge you more or deny you coverage because of that. Well, now they'd be able to. So there's all sorts of things. And I'll tell you who else is not in favor of striking down the ACA? The insurance industry. You would think, they hated it. All these regulations. No, they're loving it. I told you, they've had to pay back almost $2 billion this year just because their profits are so ridiculously high that they have to pay some back. But they're perfectly fine. They weren't thrilled with the law, but they overhauled their entire billing system, their marketing, their actuarial tables, all that crap. Their entire industry was overhauled. They don't want to go through all that again, just a decade later. So no, it's a ridiculous lawsuit, and yet somehow here we are. So
Charles,
yeah.
Can I say one more thing? Along with the continuity of coverage, something that people forget was a very common practice was rescission. If you got sick, your insurance company would interview anybody and everybody in your hospital room. They would go in and see if there was some way that they could retroactively pull your insurance because you failed to disclose a hangnail at the age of 10. And people lost their lives and lost their livelihood and lost everything because of that. And that is one of the worst parts of in my opinion, there's a lot of bad stuff, but that was one of the worst parts of it. And that's something that we have now 10 years. We have a generation at this point who doesn't know any of this stuff, who never experienced any of this stuff, who came of age after the ACA, after the exchanges actually started in 2014. So they don't know how to, the average person doesn't know how to navigate insurance. They're certainly not going to know how to navigate any of this stuff if we go backwards, which is why we have to keep fighting to go forwards.
Absolutely. That was one of I read a few stories about that at the time. It's particularly cruel because what you would do is, let's say you're healthy, or you think you're healthy, right? And so you would pay your premiums month after month after month after month, maybe for 2 or 3 years. You pay, and you never actually need, you don't really need anything beyond a checkup or whatever. And then one day you get diagnosed with cancer, or diabetes or what have you, and you actually file a claim. I need to go on chemotherapy. And so you file a claim with your insurance company, and that's when they say, aha, hold the phone, and they dig up your records. They go through, a fine-tooth comb, and they find, like you said, a hangnail at age 10. Oh, you didn't disclose that? Well, that's fraud. That's, you committed insurance fraud, so we're going to terminate your coverage. And so now they terminate your coverage at the one point that you need them the most, and you're out several $1,000s from paying your premiums when you didn't need any help. So yeah, that was a horrible, you know, and now you got to deal with chemotherapy or whatever it is. So yeah, it was a particularly nasty little practice. There's all sorts of crap like that. And like I said, with the Swiss Army metaphor, you know, Swiss Army knife, there's a lot of little things in the ACA that were just sort of thrown in there that most people have, you know, have no idea about. You know, that they're just there, and then like if they tear down the whole thing, that just it all unravels again. So on that cheery note, help flip Georgia 2 seats. Pray we don't have a coup before then. And thank you all for attending.